Not all people with late-stage Parkinson's have problems with thinking and mood changes.
But for some, problems with thinking that began in mid-stage may now be getting worse.
Mild cognitive impairment, or MCI, is when people have more thinking and memory changes than other people their same age.
It may get worse and progress into dementia, but not always. At the MCI stage, thinking problems don't usually get in the way of activities of daily living.
Even with mild cognitive impairment, most people can keep managing medicine, managing money, make sound judgments, paying attention,
planning meals, companionship, and socializing. You can live independently even with mild cognitive impairment.
But if thinking gets worse and becomes dementia, then you would need help in most areas of life. Dementia includes memory, language, visuospatial functions, mood, and sometimes hallucinations.
Visual spatial functioning lets us relate what we see to the space around us. Examples include making a bed, buttoning a shirt, and walking through doorways. It's understanding where and how we are in space.
Parkinson's disease dementia is the name of this group of thinking and mood changes. We see this happening more in late-stage Parkinson's than early or mid-stage.
Hallucinations, delusions, and confusion can happen with dementia, but they can also happen in people without dementia.
People with Parkinson's who have hallucinations often hallucinate small animals or people, often children. Sometimes they may see something at the edge of their vision that disappears when they look directly at it.
Hallucinations become more serious when the person having them believes they're real. If the hallucination is scary, it can be very upsetting.
A delusion is a false belief about a situation or people. This is more serious than a hallucination.
It's common for someone having a delusion to feel suspicious, paranoid, or even accuse their loved one of being unfaithful.
Of all the symptoms of Parkinson's disease, hallucinations and delusions are the main reason patients get placed in nursing homes.
While care partners can learn ways to manage these symptoms, it can get to be too much to carry on at home, with the care partner totally burning out.
If hallucinations or delusions begin suddenly, there's usually a medical reason for this. Always consider if the person with Parkinson's has an infection, such as a urinary tract infection or an upper respiratory infection.
Or they may have another illness or a side effect from a medicine. Call the doctor's office or urgent care.
Let them know of these changes and ask to have lab tests to rule out an infection. Report any new or sudden changes in thinking or behavior to the healthcare team right away.
If the hallucinations have been slowly developing and are now a problem, your movement disorder specialist may consider lowering Parkinson's medicine.
Parkinson's medicine can cause or worsen hallucinations, some more than others.
Consider this especially if the hallucinations began after a recent increase in medicine. In late-stage Parkinson's, you may have to choose between hallucinations and worsening symptoms.
Lowering medicine to decrease hallucinations can increase problems with movement. This is a hard trade-off.
If lowering medicine isn't an option or hasn't worked, you can treat hallucinations with medicine like rivastigmine, Exelon, quetiapine, Seroquel, pimavanserin, Nuplazid, and or clozapine, Clozaril.
Your care team can discuss these medicines with you. There are some things care partners can do to help manage their loved one at home.
These include environmental changes, respect and reassurance, and reframing and redirecting. Here are some examples of things to do.
Limit shadows by keeping the home well lit in the afternoon and evening. Allow for short breaks in between activities during the day. Don't agree that you see the hallucination. Tell them honestly that you don't see it, but that you understand they do and that it's very real to them.
Reassure them that they're safe. Distract or redirect them from the hallucination. Use humor, but not at your loved one's expense. Teasing is not helpful.
People with dementia often retain their social skills and love to laugh along with you. Don't argue or correct. If your loved one says something you know isn't true, try to find ways around the situation instead. Remember, it's the disease making the accusations, not your loved one.
Look for community resources before you need them, like your state's Board on Aging. If your loved one gets upset or acts out, remember that you can only change your behavior or the surroundings.
Try to work with the behavior, not control it. For example, if your loved one insists on sleeping on the floor, place a mattress on the floor to make them more comfortable. Here are some other things to consider.
Keep up a daily routine. Check if your loved one is wearing their hearing aids and/or glasses. Is your loved one in pain or discomfort?
Are they tired or hungry, thirsty, constipated, or holding their pee? Is there too much noise or too many people? Reduce the noise, clutter, and the number of people in the room. Limit caffeine and sugar. Try gentle touch.
Soothing music, walks, and speaking in a reassuring voice. Don't try to restrain the person, but rather distract and redirect with a snack or an activity, or a conversation about a pleasant memory.
Engage them in a simple chore like folding washcloths. Keep calm while you talk. Avoid speaking sharply or raising your voice.
Safety is number one for both the care partner and the person with Parkinson's.
Don't hesitate to call 911 if you need help. Other mood issues you may see include feeling down, hopeless, anxious, stressed, or less motivated.
Most mood changes can be treated, but it may take time to find the right treatment. It's very important to work closely with healthcare experts, like your movement specialist, specialty pharmacist, psychologist, and psychiatrist.
Exercise, getting enough sleep, talking to a counselor, and staying socially active can all improve mood. This is true for care partners too. Communication isn't just about the words we say. It's also about how we say them, the meaning behind them, being able to understand them, and the facial expression we use when we speak them.
Communicating becomes more difficult as Parkinson's progresses, causing anxiety, loneliness, and insecurity.
Speech can become slower or faster, slurred, breathy, hoarse, and quieter. Stuttering and repeating sounds can also make it hard to be understood.
Thinking changes can affect how we understand the meaning of words. For the person with advanced Parkinson's, coming up with the words,
following the conversation, and following plot lines on television or in books can be very hard at times.
It's almost impossible to have a conversation while doing something else. Being asked to repeat yourself time and again can be frustrating and tiring. For all these reasons, you may choose to no longer be around other people. This can lead to loneliness.
The care partner has a key role, and communication is at the base of that role.
Ask your loved one how they feel about receiving help from you and express how you feel about giving help.
When you speak, make sure you're in a well-lit area where your loved one can see your face.
Avoid speaking from far away, like from the kitchen into the living room. Facial expressions go a long way to convey meaning.
Here are some other tips. Talk in a quiet place. Turn off or lower the TV. Tell your loved one the topic of your conversation before you start speaking.
Stay on one topic. Don't change the subject without warning. Use your body to point things out to convey meanings.
Sometimes a thumbs up is all that's needed to let the person know that you understand. Hold up your hand to let them know you have more to say.
Care partners should use a normal tone of voice. Don't yell. Ignore errors if you understand the message.
Use simple, short phrases and ask yes or no questions. Give instructions one step at a time.
Only giving the next step when the one before is done. Give your loved one time to speak. Staying patient during these times can be very hard.
Although most people with Parkinson's can eat normally, some have trouble swallowing. This is called dysphagia.
Dysphagia doesn't necessarily get worse with the length of time you've had Parkinson's,
or if other symptoms are advanced. In fact, while dysphagia is common in Parkinson's, it's rarely bad enough to need a feeding tube.
But a feeding tube might help if you need extra nutrition.
In some cases, you can still eat and drink through your mouth, even if you have a feeding tube, if you're willing to accept the risks, such as choking or aspiration pneumonia.
Some swallowing problems include trouble controlling how fast or slow that food or liquid goes in, keeping food in your mouth without swallowing it, called pocketing.
Eating food too quickly or without thinking, or very slowly because it's hard to get food from the plate to your mouth.
Some people have these problems in many stages of Parkinson's, not just late stage. The swallow reflex is very complex.
Trouble swallowing puts the person at risk for aspiration pneumonia, weight loss, dehydration, and embarrassment when eating in a social setting.
It can also lead to decreased quality of life due to having less pleasure in eating. Ask your doctor for a referral to speech therapy to gauge any speech or swallowing problems.
They can also help you with social interactions. Consider seeing an occupational therapist to gauge how you're doing with eating and drinking.
They can recommend equipment like easy grip utensils that can help you eat on your own.